So my name is Mark. I'm the research director for Harvard's program in global surgery and social change, and an assistant professor of ENT and of global health at the Harvard Medical School. And I've set myself a little bit of a daunting task for the next 35 minutes. I want to talk about the past, the present, and the future of this field of global surgery, this field of surgery in low-income countries, this field that we all work in, whether or not we use these two words to describe it. And I said 35 minutes because I've been given 45 minutes to speak, but I tend to structure my talks to be 15 minutes less than the time allotted to speak, because I don't think communicating with just sort of standing in front of you and declaiming knowledge from on high is as effective as a conversation. We're a bit of a smaller group here, so if at any point, there's buffer space in here, if at any point you want to ask a question, you want to push back at me, you want to tell me I'm wrong, you want to tell me to dive deeper into something, you want to call me an idiot, all those things are perfectly fine. And if you raise your hand and I don't see you, just call out. Deal? Yeah. Okay. So let me motivate this talk with two quotes. The first is from the late Chris O'Brien. Chris was a head and neck tumor surgeon in Sydney, Australia. He died about 10 years ago of a brain tumor. But what Chris used to say is that the one thing you never do is destroy a patient's sense of hope. I'm going to tie this quote in with a quote from somebody that you probably know. Gary Parker is fond of saying, for hope to be credible in the future, it must be tangible in the present. Keep these two ideas of hope in mind. I'm going to come back to them explicitly at the end of this talk. But keep them in mind also as I introduce you to two patients. The first is a patient of mine from Madagascar. Her name is Patricia. She's had this tumor growing off the right side of her face, for the last 30 years. The second patient is Mercy Ship's most famous patient, Sambani. He's had this tumor growing off the left side of his face, also for the last 30 years. Now, I'm going to develop Patricia and Sambani's stories a little bit later on in this talk, but I want to pause here on these pictures and say that we at Mercy Ships tend to look at pictures in patients like this in one of two ways. Either we look at these tumors and we think, we can fix this. And it's true, we can fix this. This is what we do. This is what the organization has been doing for 40 years. This is what we do day in and day out. We can fix this. Or we tap into our humanity and we say, Patricia, for 30 years, nobody has seen you. They've just seen your tumor. Somebody, nobody looks you in the eye. They look you in the tumor. I see you. Two incredibly important ways to look at pictures in patients like this. But I want to encourage us, at least for the next half hour, to look at these pictures, look at these tumors in a third way. Not just to see the tumors as something we have to take out, but also not to disregard the tumors altogether, but to see them for what they are, symptoms of a deeper, underlying, systematic disease that I think we in the global surgery community are duty-bound to diagnose and to treat. And that's what I want to talk about today. I'm going to start with a 500-year step backwards and develop the history of global surgery over those 500 years in 10 minutes. Then I'll talk about the present of global surgery through the lens of this Lancet Commission on Global Surgery, which was published in 2015. Some of you may have read it, some of you may not be familiar with it at all, so I'll give a little bit of an introduction to the Lancet Commission on Global Surgery and how it can help us view the present of global surgery and how it frames the future of where global surgery is going and where we can be a part of it. I have nothing to disclose. These are my two current funding sources, but they have nothing to do with this talk, and you won't see them mentioned ever again after this slide. So, let's start with the history of global surgery. And in the 10 minutes that I've allotted myself to talk through the history of global surgery, I'm not going to be able to dive very deeply into any one event in that history. I'm going to have to skim across the surface on purpose. But in that skimming, I want to develop a thesis that surgery has been a part of global health for as long as global health has existed. Now, this thesis flies in the face of things we've heard, things we may even have said, things like this quote from Paul Farmer and Jim Kim in 2008, that surgery is a neglected stepchild of global health. And on the face of it, Farmer and Kim are right. If you look at the number of mentions of international health in books from 1800 onwards, you see a steady rise in mentions starting in about 1880. In the 1960s, international health as a phrase became a bit taboo and it was replaced with global health. But global surgery doesn't appear on this figure at all. So for me to make this claim that surgery has been a part of global health for as long as global health has existed is going to take some doing. But in that doing, I want to highlight two derailments, two places where surgery has either derailed itself or been derailed from the global health conversation happening around the world. Because I think if we talk about these derailments, it'll give us a sense of what we can do, what we can try to avoid to do, actually, in the future of global surgery. So let's now take that 500-year step backwards. Modern global health truly started with missionaries and with merchants. It started with missionaries like Matteo Ricci, a Jesuit missionary to China in the 16th century. Ricci did a bunch of things. He worked in astronomy, he worked in what was called calendrical science, and he worked in the treatment of malaria. He himself was not a surgeon. The first surgeon that I could find working in what we would now call global health was just across the water from him. Caspar Schamberger was a German surgeon employed by the Dutch East India Company. And he began the study of Western medicine in Japan. His school of thought continues in Japan to this day. The Protestants entered the fray a little bit later. Thomas Richardson College was a medical missionary to China. He only spent 4 years in China. But in those 4 years, he became known for doing eye surgery. So well known for doing eye surgery that this painting that commemorates him with two eye surgery patients, this one in the middle and this one on the left waiting for his surgery. The first full-time medical missionary that I could find to China was Peter Parker. Parker spent over 2 decades in the country, and in that time, he trained 2,000 surgeons. So surgeons are part of this global health thing from the very beginning, but this very beginning is happening still in the prehistory of global health. It's happening over here. We're not talking about international health as a thing yet. We're not putting those two words together, writing about international health as some sort of field. 2 other events happen, in this prehistory. The founding of the ICRC in 1863 and the Salvation Army in 1865. And now we're off to the races. Now we start writing about international health as a field. It's a thing now that people start thinking about. And we do that with some measure of frequency. Right before World War I, that measure of frequency increases and then increases again right before World War II. These spikes correlate completely coincidentally, but they correlate with the founding of 2 mission hospitals that still provide surgery today, Kijabe in 1910 and Tenwek in 1935. All right, so we're going on this international health spree, writing more and more about it until we hit a peak in 1948 with the founding of the WHO. Now, if you haven't read the Constitution of the WHO, it's likely that you've heard or read the first line of the Constitution of the WHO, in which the WHO defines health as a state of complete physical, mental, and social well-being, and not just the absence of disease or infirmity. This is a pretty cool definition of health. It's broad, it's ecumenical, it should encompass everything that we do, surgery and otherwise. Every doctor, every nurse is part of this. Except this is the first derailment, because within the very constitution of the WHO, just a few lines down from this broad ecumenical definition of health, the focus of the WHO is narrowed to 2 things: communicable disease and the healthy development of the child. So at the WHO, surgery is no longer there. And you can see this reflected in writings about these things. Writings about child health far outstrip writings about anything else on this figure. This derailment, this divide between surgery and officialdom in global health, deepens in 1978 with the Alma-Ata Resolution. At Alma-Ata, health is declared a human right, a fundamental human right. The highest attainable standard of health is a fundamental right of every human being. is the Alma Ata Declaration, and every country signed on to it, including the US. So again, ecumenical, huge, surgery should be a part of it. But once again, this broad ecumenical definition of health is narrowed to primary healthcare. Now, it's not as if surgeons aren't working in global health at this time. Right around Alma Ata, you have the founding of 4 large charitable organizations. Samaritan's Purse in 1970, MSF in 71, Mercy Ships, I've heard of it, in 1978, Orbis in 82. In fact, this sector of global health, this charitable surgical sector, has mushroomed. At our last count a year and a half ago, there were 403 charitable surgical organizations. 2/3 of them operate using a short-term mission trip model, which is antithetical to what the WHO says works in global health development. It's antithetical for a good reason. We're not going to go into the research of why it doesn't work, but it doesn't work. And yet 2/3 of us in surgery use this mission trip model, fly in, do some surgery, fly back out again. We operate in 139 countries, and we are based primarily in the US, Canada, the UK, India, and Australia. Now there's one ray of hope at this time. And it's a speech given by Halfdan Mahler in 1980. Mahler was the Director General of the WHO at the time of the Alma Ata Resolution. In this speech, he says, surgery clearly has a role to play in primary healthcare. But look at the role he gives us. We exist just to lend credence to primary healthcare systems. Without surgery, people will not have faith in their primary healthcare systems. He does go on to say that although these are high priority matters for everybody, the vast majority of the world's population does not have access to skilled surgical care, and little is being done to find a solution. Alma Ata, 1978. Halfdan Mahler's speech, 1980. And nothing is done to find a solution for 25 more years. Until, in 2005, the WHO founds the Global Initiative for Essential and Emergency Surgical Care, run currently by Walt Johnson, pictured here. 2009 sees the publication of the WHO's Manifesto on Safe Surgery Saving Lives and the Safe Surgery Checklist, which we use on the ship. And now, all of a sudden, in those 25 years, surgery is back. Right? We're back at the WHO. The WHO cares about us. There's manifestos being written about us. And you see this reflected, in research. The number of research publications in global surgery has quintupled over the last 15 years. And it's at this time that 2 key research papers are published. In 2006, Haile Debas publishes his estimate that 11% of the world's disease burden is surgical. 2010, Funk et al. Published their estimate that 2 billion people around the world don't have access to an operating room. With all due respect to Debas and to Funk, this is the second derailment. 30 years previously, Halfdan Mahler had said the vast majority of the world's population doesn't have access to skilled surgical care and nothing is being done to find a solution. 30 years previously. 30 years later, we say, well, it's not the vast majority. It's only 2 billion, but 5 billion are doing just fine. We tell the world's community that 90% of their diseases don't need surgery. So we essentially tell everyone that there's not a lot of disease burden for surgery at a time when people think surgery is really expensive, really complex, and there are 403 charitable surgical organizations taking care of the problem anyway. So why should the world care about surgery? The world should instead be investing its global health resources in things that will give it more bang for its buck. Things like malaria bed nets, things like vaccinations, things like antiretroviral therapies for HIV. And it's into this space that Farmer and Kim can write that surgery is the neglected stepchild of global health. But it's also into this space that The Lancet, the large British medical journal called The Lancet, can actually commission a commission on surgery in low-income countries with a few aims. One, to take these statements in the second derailment and ask, are they actually true? To take this mushrooming of research in global surgery that had lacked focus and a coherent, unified voice, and unify it into a global voice on global surgery. And to that end, the Lancet Commission became a collaboration of commissioners, advisors, researchers, and others from 111 different countries, united around the central tenet that what the world deserves is universal access to safe, affordable surgical and anesthesia care when needed. This is a really packed phrase, and I'm going to unpack it in 2 slides, but I'm going to quiz you on it in 2 slides. If you remember nothing else from my ranting and raving up here today, just remember this, that what we are aiming for is universal access to safe, affordable surgical and anesthesia care when needed. So the commission itself, as I said, published in 2015. It's a 53-page report. I'm happy to email it to anybody who's interested in reading it, but it's broken up into 3 sections: key messages, recommendations for surgery, and metrics for measuring surgery. And I want to spend most of the time on these key messages because there are numbers in these key messages that you're starting to see in the scientific literature, starting to see in the lay press, you're starting to see in our own Mercy Ship's promo materials, and I want to give you some background for where those numbers come from. So, let's get back to the central tenet, which is I heard a universal access, I heard a safe, I heard an affordable. These are good. No, these is when needed. All right, so this is the crux. Universal access to safe, affordable surgical and anesthesia care when needed. So let's unpack this phrase. True access to any health intervention requires 4 things. Requires that that intervention exist, requires that it's safe, that it's affordable, and that you can get to it in time. And the first question before the commission that we had to answer was how many people around the world don't have this sort of access to surgical care? Right? Funk's paper seemed to suggest that that answer was 2 billion. But having access to an operating room is literally just one of these domains. Who cares if there's an operating room if it's not safe, if you can't afford it, or if you can't get to it in time? And the other problem with Funk's estimate, I've kind of already alluded to, is that an estimate of 2 billion people not having access to surgery means 5 billion people do just fine with surgery, and that does not sit very well with the reality on the ground. Because the reality on the ground is there is a lot of reluctance to seek surgical care. Sometimes that reluctance is simply because of a lack of knowledge that surgery can treat what you have. This happens with cataracts often. But often it's because of a fear of safety, of quality, of affordability, etc. And if you decide to seek surgical care, that care is too far away. This is the WHO's estimates of the median distance between you and your nearest health facility if you're in a high, a middle, or a low-income country. In high-income countries, we are 5 kilometers away, 3 miles away from our nearest hospital. Low and middle-income countries, 30 to 35 kilometers away. But what's most telling to me on this slide is not those horizontal lines, it's the rectangles, the interquartile range. What that means is that fully 25% of the population of low and middle-income countries lives more than 65 kilometers away, more than 40 miles away from their nearest hospital. Now, I just drove 95 miles in an hour and a half. 40 miles in East Texas is not a big deal. But 40 miles in rural Madagascar, where Patricia and Sambani are from, that can take you days. But hypothetically, let's say you've got a tumor growing off the left side of your face, and you've decided, I need to see somebody. So you make that days-long trip to get to a hospital, to get your surgery. That surgery may not be available, or it may not be safe. This is the WHO's estimates of the proportion of hospitals that don't have electricity, 1/3, running water, 1/5, oxygen, 1/4. Half of the world's hospitals don't have a postoperative care area. Now, this finding dovetails with one of my favorite papers ever published. It was published about 5 years ago by Margaret Crook, Renee Shaw, and others. They looked at 700 hospitals in 5 sub-Saharan African countries. And they asked, forget staffing, forget distance, forget all the things that I've been talking about right now. Let's just look at infrastructure. How many of these 700 hospitals have the infrastructure necessary to provide surgery and emergency care reliably? 700 hospitals, 5 countries. The answer was 0. Not a single hospital met the WHO's minimum standards deemed essential for the provision of emergency and surgical care. But let's say you're lucky, you've made that days-long trip, you find that one needle in a haystack hospital that Renee and Margaret missed. You get there for your surgery, there may not be a surgeon waiting for you. Every country on this map that is not blue, every country that's red, yellow, orange, orange, purple, etc., is a country that has to scale up its surgical services just to meet the bare minimum surgical requirements of its population. We're talking C-sections and appendectomies, not the sort of stuff that we do on this ship. And Madagascar, where Patricia and Sambani are from, definitely not blue on this map. Cameroon, where we're docked right now, definitely not blue on this map. So, if I put all of these things together, if I put availability and safety, timeliness, and I haven't even touched affordability yet, I will in a bit. If I put all of these things together, it's not 2 billion people around the world that can't get surgery. It's 5 billion. It is literally 70% of the world's population that can't get surgery today. And that's the first key message of the Lancet Commission, which dovetails nicely with the second key message, which is that we just aren't doing enough surgery in the right places. Every year, 313 million operations are done around the world. A third of the world's population lives in low-income countries. Raise your hand if you think a third of the world's surgeries happen in low-income countries. 25%? 10%? 5%? 2%? You guys are pessimists. It's 6%. So 6% of the world's surgical volume is placed on 33% of the world's population. To meet this unmet need, to fill this gap, we would need to provide an additional 143 million more operations every year. This averages out to about 5,000 procedures per 100,000 people in the population of any one country. And to achieve this, the country needs to train between 20 and 40 surgeons, anesthesiologists, and obstetricians, SAO providers, surgeons, anesthesiologists, and obstetricians, per 100,000 people in the population. Remember these two numbers, 5,000 and 20 SAO providers, because they're going to come back in just a second. But that's key message number 2. Key message number 3 is the one that I missed earlier, which is for patients, surgery is really expensive. Every year, 81 million people, that's 10 times the population of New York City, 4 times the population of the entire country of Australia, are driven into poverty by the costs of surgery. That means that 25% of people who get surgery every year are cured into destitution. But that's just the people who are getting surgery. I just spent key messages 1 and 2 talking about how people who need surgery aren't able to get surgery. If you needed surgery today, you have a 50-50 chance of being impoverished by the cost of surgery. Half the world's population is at risk, and that half lives in the places that you think they'd live. Sub-Saharan Africa, South and Southeast Asia. So, key messages 1, 2, and 3 are a little bit depressing. Key message 4, though, says, 1, 2, and 3 are the state of the world as they are right now. 4 says, we can fix this. Not only is fixing this feasible, but it makes economic sense. It would cost the world $350 billion to fix this problem over 15 years, which is a large number until you realize that it costs the world $12.3 trillion in GDP losses if we don't do anything about it. So, macroeconomic no-brainer. It's also a microeconomic no-brainer. Let's go back to this second derailment here and ask the question, is surgery too expensive? Surgery is expensive. But for us to say that surgery is too expensive, we're saying that we're just not getting enough value for the cost that we're putting into it. And to answer that question, this is a little bit of a busy slide, but this is a systematic review of the cost to buy a healthy year of life for a number of global health interventions. So global health interventions in blue at the bottom are ones that we pretty much all think we should do. Bed nets for malaria, vaccines, for pertussis, tetanus, polio, for tuberculosis, antiretroviral therapy for HIV, which costs between $450 and $650 US to buy one healthy year of life. And we've said, great, buying a year of life for $450 US, that is a good deal for us. That's a good buy for us. Well, if we truly believe that, and we're consistent, look at the numbers for surgery in red. They are all less than $450 US. So surgery is a macroeconomic no-brainer. It's a microeconomic no-brainer, and it is feasible. Some countries have actually scaled up to 5,000 procedures per 100,000 people in the population. Mongolia has done so recently. Which brings me to the fifth key message, which I think should have been our first, which is that surgery is an indivisible, indispensable part of a functioning healthcare system. Now, I realize I'm preaching to the choir here, but if I came up to you and I said, I founded my own country, and I'm currently working on designing the health system, and I think I can keep my population healthy without doing surgery, you would want to know what I was smoking. And you would not sign up to be a citizen in my country. And yet, despite that super obvious example, it has taken the WHO 70 years before it actually came out with a resolution saying that surgery is an essential part of universal health coverage. That just happened in 2015. And why is it essential? Well, first of all, it's not 11% of the world's disease burden that is surgical. It's 30%. And that 30% distributes itself across all disease categories. We as a global health community have made a commitment to lower maternal mortality down to as low as possible. We're not going to be able to do that without surgery if 35% of maternal admissions require surgery. We won't make a dent in cancer mortality if 62% of cancer admissions require surgery. Excuse me. So I want to make a really important point here, and that is that we're not trying to set surgery up as sort of surgery instead of maternal health, surgery instead of non-communicable diseases, surgery instead of cancer. It's surgery because of. We want to lower maternal mortality, we want to lower cancer mortality, and we can't do it without surgery. So those are the Lancet 5 key messages. 5 billion people around the world don't have access to safe, affordable, and timely surgical and anesthesia care. 143 million more operations have to be done every year. 81 million people impoverish themselves with the costs of surgery, and half the world would if they needed surgery. But fixing this problem is feasible, it makes economic sense, and it is necessary for the world to meet its global health goals. Which brings me to this. Key messages 1, 2, and 3 are a bit of a point A. Right? They're where we are right now. Key messages 4 and 5 are point B. They're aspirational. They're where we want to go. The question is, how do we get from point A to point B? And here the Lancet Commission is a little bit less helpful. They had 2 recommendations for this problem. Recommendation number 1, fix the problem. But before you can fix a problem, you have to measure the problem. And until 2 years ago, the world was not measuring surgery. In keeping with that first derailment I mentioned at the very beginning, we would every year measure 206 indicators in child health, 99 indicators in HIV, 67 in tuberculosis, 0 in anesthesia, 1 that mentioned an operation. So the first thing that we did in the commission is come out with 6 indicators by which we could measure the health of a surgical system. 2 of them are around availability, 2 around provision and outcomes, and 2 around this financial catastrophe that patients go into getting surgery. And these indicators were accompanied by targets, what we should be getting to by 2030. So for indicator number 1, the population of any country by 2030, 80% of that population should be within 2 hours of a hospital that can provide surgery. And every country should have 20 SAO providers, surgeons, anesthesiologists, and obstetricians per 100,000 people in the population, producing, indicator 3, 5,000 cases per 100,000 people in the population. I'm going to kind of gloss over indicator 4, it's the perioperative mortality rate, and go to indicators 5 and 6, which are around that financial catastrophe that patients face when getting surgery. And the UN, the WHO, and the World Bank all came out in 2014 to say, we want to end this. We want to end financial catastrophe due to medical care. We said, great, surgery is part of medical care. We've got to do that for surgery as well. Now, the reason I belabored this is because this set of 6 indicators starts to give us a little bit of a lens with which we can, as I said at the very beginning, start to diagnose and maybe have ideas for treating the deeper underlying systematic problem that produced Patricia and Sambani's tumors. Because their stories are a litany of the barriers that patients in low and middle income countries face when trying to access surgery. In her 30 years, Patricia had been to see a number of surgeons. None of them wanted to offer her a procedure that she could afford. In Sambani's 30 years, he'd been to 10 different hospitals. 3 of them had surgeons in them. None of them could offer him a procedure. We were docked on the east coast of Madagascar. Sambani was from the south of Madagascar. That trip from the south to the east required that he be carried on somebody's back for 2 days just to get to the nearest road. Then it was a 6-hour trip up the road to get to the hospital. So already, I've talked about barriers of distance, of transportation, of a lack of providers, a lack of procedures offered by providers. The barrier that interests me the most in my own research, though, is this. So Patricia and Sambani surgeries, as you know, were offered to them for free. The surgeries, the medications, the rehab, everything at no cost to them. And yet, to make that 2.5-day trip from his rice farm in the south to the east of Madagascar, Sambani had to sell his rice paddy. So he was one of those people who faced a catastrophic financial event to get his health care. So we can then start looking at the stories behind these tumors through the lens of these 6 indicators, where Madagascar should be in 2030, but where it is right now. Only 29% of the population can actually get to a hospital within 2 hours. So if you're shot in the stomach or you're macheted in the stomach, for 71% of the population, that is a long drive to get that taken care of. The surgeon density in Madagascar is not 20 per 100,000 or 10 or even 1, it's 0.8. And they're only providing 191 cases per 100,000 people in the population, and 95% of the Malagasy population, if they need surgery today, will be driven into poverty by its costs. So, where do we go from there? Here is where the Lancet Commission becomes a little bit less helpful. The Commission's second recommendation is to fix the problem, but is to fix the problem at the national level. Countries have national plans for HIV. They know where they are with HIV. They know where they want to be with HIV in 5 years. But in a lot of countries, surgery happens in the shadows. Ministers of health can't tell you how many surgeons are in the country or how much is being spent on surgery. And so the Commission said that needs to change. There need to be national surgical plans, just like there are national HIV plans. I will put money on the fact that most of us in this room didn't go into our professions because we want to go live in the ministry and develop national surgical plans. What does this mean for us here who went into our professions because we want to help? How can we actually be involved now in this future of global surgery where there's academic interest and governmental interest in this field of global surgery? How can we remain relevant in this? Well, I'll start with the obvious one, dovetailing on something that Donovan said. Mercy Ships is built very solidly, as you all know, on a pillar of surgical delivery. 143 million more operations need to be done every year. We're doing 2,000 of them every year. We do this. We do this well. Over the course of, since the Africa Mercy came on board, we've been involved in one-on-one mentoring with anesthesiologists and nurses and surgeons, and the mentorship training capacity building has really significantly grown in the next 5 years. And the recognition that just sort of doing the one pillar of just doing some surgeries is not enough if we sail away and leave nothing behind. We have also started to advocate for these national surgical plans at the international stage with the WHO and the World Bank. But if you're honest, at their base, these three pillars are pillars of doing stuff. And the history of global surgery is littered with well-meaning surgeons and organizations doing stuff, predicated on the assumption that just by being here, we are doing good. Now, as an academic, as a humanitarian, this assumption does not sit well with me. And I think in this future of global surgery, it behooves us to start turning this assumption on its head, to start asking the question, just by being here, are we doing good? And to be honest with that. So I want to give you a couple of examples of how Mercy Ships has started asking this question as well. I'm also going to give it to you, primarily give you these particular examples in addition for the IS department that ends up maintaining these databases of all these surveys that we do where we ask patients, do they have a mud hut or do they have electricity? I want to return to you all the work that you guys are doing on that. So in October of last year, Mercy Ships published a spate of papers all around these 6 indicators. We published papers on barriers to care, papers on checklist training, on training in sterile processing and sterility, and papers on screening strategies and transportation. And I want to focus on those last 2 papers and ask 2 questions. We claim that we reach the poorest of the poor. Do we? And if we don't, how can we do better? Let's start with that first question. Do we reach the poorest of the poor, which comes from that really bizarre database that you guys are maintaining about what people sleep on. With this information that we get from patients, we can figure out relative to their community, how wealthy or poor these patients are. So we can put them in sort of a wealth spectrum. We asked this question in Madagascar, where we were for 2 years. In the first year in Madagascar, we screened patients the way we'd always screened patients before in large mass screening events in the big cities. 70% of our patients came from Tamatave and from Tana, the capital city. 30% came from the outlying cities. And we absolutely did not reach the poorest of the poor. 60% of our patients in MATA 1 came from the richest quintile in the country. 4% came from the poorest quintile. Now, you could do one of 2 things with this. You could get depressed. Or the reason to do things like this is because we can respond to it. And in MATA 2, the screening strategy changed drastically at the cost of a lot of time for the screening team, a lot of money for the organization. We pushed way out of Tana and Tamatave. 70% of our patients in MATA 2 came from the outskirts, and only 30% came from the big cities. And it worked. We tripled the proportion of patients that came from the poorest quintile, and we increased the proportion of patients that came from all 3 of these poor quintiles. Now, this is good. It's not quite fully reaching the poorest of the poor. It's not quite a fully equitable system, but it is way better. The question then is, can we do better, and how can we do better? In the last 2 years, the screening team has been following up with patients whom we schedule for surgery, but who don't show up for surgery, asking them why. What was the reason that you didn't show up for surgery? The most common answer, even though we offer free surgery, is that they couldn't afford it. They specifically couldn't afford the transportation. The very thing that drove somebody into poverty, most patients were not willing to actually face it. So we started looking at that. There was a subset of patients that for some reason or other had actually had their transportation paid for, so we looked to see what happens to the no-show rate if transportation is paid for. Controlling for all confounders, our no-show rate if we don't pay for transportation is 30%. Now, it's going to come as no surprise to anybody in this room that if we pay for transportation, the no-show rate's going to go down. Water is wet, the Pope is Catholic. But what shocks me on this is how much it goes down. If we pay for transportation for our patients, we drop the no-show rate in half. So we're responding to this now. In October of 2018, October of this year now, we'll be starting a randomized controlled trial of different ways of paying for transportation for our patients to see if this actually is borne out prospectively. So we've got these pillars, and we're starting to build a pillar of research and evaluation. But what does it mean, I think, to be relevant in the future of global surgery is not this, but this. Because imagine how powerful it would be if we could go to a Ministry of Health and we could say to the ministry, look, we deliver a lot of surgery and we know we do it well because we've studied it. We know our outcomes. We do a lot of training and we know the training is effective because we've studied it. We can help you advocate at the international level for national surgical planning, and we can also train your scientists. Choose. How best can we help you? Because as clinicians, as surgeons, we're incredibly good at taking patients from here to here. We're really good at making that hope tangible in the present. But what we have to do now is start to make that hope credible for the future of the health systems that Patricia and Sambani go back to when we sail away. Thank you very much.